This presentation is going to focus on the health assessment of the thorax and lungs. Our objectives are by the completion of this module, the student will be able to identify the lobes of the lungs, distinguish between normal and abnormal lung sounds, relate abnormal lung sounds to possible physiological changes, to practice assessment skills with thorax, and to describe underlying conditions related to abnormal lung sounds and assessment findings. As far as the head-to-toe assessment goes, when does this fit into my assessment? You want to do this assessment right after your neuro exam. What equipment do I need? You'll need a stethoscope and a pulse ox, as well as a blood pressure cuff for baseline vitals. How do I start? You want to start by getting to know the patient, introducing yourself. Step one is the physical appearance and inspection of the chest and thorax. You want to look and note the shape of the chest. You want to look at the rate and rhythm of the respirations. And a key pointer here is to not let the patient know that you're taking a respiratory rate or looking at them. Whether you do it while you're doing something else or kind of distract them by talking to them while you still have your eye on them to count the respirations. Does the patient seem to be uncomfortable or in distress while breathing? And is the patient using both nares and mouth for breathing? You want to see if they're just using their mouth, if there's nasal flaring while they're breathing. You just want to take a look at them. Abnormal findings of the inspection are a barrel-shaped chest. This might be a sign of a chronic respiratory illness such as emphysema. The patient may use accessory muscles to breathe such as the neck or stomach. You can notice that when you're just watching them breathe. They might have a decreased respiratory rate. This could be because they're sedated, maybe heavy use of narcotics, or they're sedated for another reason. They might have an increased respiratory rate. This might be because of their increased work of breathing. Over here is the picture of the chest. So the one on the left is a normal chest. The one on the right is barrel-shaped chest. You can see how it's kind of rounded like a barrel. Step two is the background information of the patient. So you want to ask the patient, do they have any current illnesses? And you might actually already know this from reviewing their chart if they're there for an acute reason. Does the patient have a chronic condition related to respiratory problems? So do they have asthma? Do they have chronic bronchitis? This would be good to know beforehand, before actually doing your assessment. Do any medical conditions run in the family? You want to ask them specifically, because some people will say, no, everyone's healthy, but then you say, does someone have asthma? And then they start naming people in their family that have issues. So you want to be specific when getting a medical history and a family medical history. Does this patient smoke? If they say yes, you want to get specific. You want to ask them how often, how much, for how many years. So if they say they smoke a pack a day for 5 years, it's measured in pack years. So that would be 5 pack years. If they said they did a half a pack a day for 10 years, that would still be 5 pack years. So you want to actually figure this out for your documentation. How much physical activity does the patient participate? So you want to find out, are they working out every day? Do they go on daily walks? Have they not worked out in years? You want to ask them how much physical activity they get. And what, if anything, causes the patient to become short of breath? So you want to be able to identify whether walking up a flight of stairs or going to get the mail in the morning, what actually causes them to be short of breath, if anything. So after you've obtained that background information, you're going to start by palpation. You want to wash your hands before and after any physical activity with the patient, of course, and be wearing gloves. Palpation and percussion allows for abnormal findings in the chest. This might be something you might not see, but you could actually feel. You want to look for abnormal bony prominences and skeletal malformations. And you want to percuss for resonance in a logical pattern. So you want to be able to put 2 fingers on the patient's chest and with one hand, and on the other hand you want to be tapping on your knuckles as you move across the patient's chest. A logical pattern might be this one pictured here, where you start from left to right and go down. However you want to do it, but you want to make sure you're covering all your bases. Step 4 is auscultation. This is actually listening to the lung sounds. So you want to remember to assess all 5 lobes of the lungs. And I showed this picture here so you can see how much of the surface area is covered by each lobe of the lungs. So you always want to remember to actually put your stethoscope underneath the armpit almost, a little bit below the armpit, right below the nipple line. That's actually a frequently missed spot, but that will get you to hear some of the bases of the lungs. You want to listen to breaths by having the patient breathe normally first. And then you want to have the patient cough to listen for congestion or secretions. You also want to note the difference. If you've heard some sort of adventitious sound before the patient coughed and then it was cleared with cough, that's good to note. So the normal findings of the lungs. So the patient should not become short of breath from taking a deep breath. Normal findings are clear sounds with no high or low pitches. And the patient should not cough from taking a deep breath. Normal respiratory rate is 12 to 18 breaths per minute, and it's, again, really important that you not let the patient be able to tell that you're counting the respirations. I know it sounds silly, but basically the patient might kind of concentrate on breathing rather than just doing what they've been doing while they've been in bed. So let's listen to some abnormal lung sounds. The first one is wheezing. Wheezing may occur in inspiration or expiration. It might be present in asthmatic patients. Let's listen. The next one is stridor. Stridor is caused by an upper airway narrowing or obstruction. This may occur in children with croup or pertussis. You can hear that high-pitched sound, almost like air is trying to be pushed through a narrower space. It might occur when the airway is blocked by an object also. The next lung sound is coarse crackles, also called rouse. It's present in patients with pneumonia or bronchitis often. Let's listen to coarse crackles. Can be heard in one or both sides of the lungs, and it's kind of like a wet popping noise. Could be caused by fluid in the airway. The next one is fine crackles. This can be heard in patients with bronchitis and pneumonia as well. And it's a higher pitched sound than the coarse crackles. Sometimes you can hear it across the room without even a stethoscope. Let's listen to fine crackles. You can really hear the wet sound in the fine crackles. You can really hear that wet, crackly sound more than the popping sound. It's more of a crackle with the fine crackles. The coarse crackles includes that popping sound. The next one is rhonchi, also called low-pitched wheezes. People will say there's a low-pitched wheeze. You can also call that rhonchi. It's kind of like a rattling sound. It can sometimes be cleared by coughing. Let's listen to rhonchi. It's very subtle, but there's a very low-pitched wheeze you can hear if you listen closely. The next is the pleural friction rub, and this is actually when the pleural tissues are rubbing together. You kind of hear like a squeaking friction sound. It may be found on patients with pneumonia or other lung conditions. Let's listen to that. You can really hear that rubbing sound, rubbing together sound. And this will not be cleared by a cough. So if this is going on with the patient, this is something that's not going to be cleared when they just clear their throat. So documenting your assessment. As nurses, we're not diagnosticians. Our biggest asset is actually our assessment skills. We want to be able to identify abnormal findings, and we want to be able to anticipate the plan of care based on what we're finding. So we want to make sure we're specific about what we're hearing and where we're hearing the adventitious sounds. We want to note whether there's sputum present and note the consistency and color as well as the amount. This might be described as frothy, thick, it might be green, yellow, it might be blood tinged, and you might consider it small, scant, moderate. Document the presence of a cough. So you want to note whether you're hearing the patient cough before you even started anything. And if they're coughing just while you're assessing them, you want to note that as well. You want to document the presence of shortness of breath. This would mean that the patient was complaining that they needed to catch their breath, or you could just notice the use of accessory muscles while they're breathing, as well as just coughing while breathing. You want to document the respiratory rate and pulse oximetry. So you'll be counting respirations again without the patient knowing, and the pulse ox will go on the finger of the patient, and that will be able to identify the oxygen saturation for the patient. You want to consider taking a baseline set of vitals before actually assessing and listening to the lungs. You can take a blood pressure and a heart rate and a respiratory rate before you begin your assessment and compare that to the assessment after. Practice makes perfect when it comes to lung sounds. A lot of them sound so similar, so you want to continue with this module by reviewing the case studies. You also want to complete the self-check quiz to test yourself and familiarize with the lung sounds. So you can go over those over and over again, and don't be afraid to also practice on a friend too. You want to listen, get used to where you're listening. Focus back on that diagram I showed. I'll actually post that also on the module, so you can see where you actually hear when you're listening to the lobes of the lungs, where to put your stethoscope on the chest.